Good afternoon, ladies and gentlemen. First of all, I'd like to thank the organizers for the kind invitation to participate in the National Glaucoma meeting. I have been asked to talk about complications in childhood glaucoma surgeries, and I shall speak on preventing complications today, as this is the key to ensure success in managing these children. In addition, understanding how to prevent complications will also make us better equipped to manage them. So why is pediatric glaucoma considered to be the most challenging in the field of glaucoma? First, it is uncommon compared to adult glaucoma. It's difficult and time-consuming to examine and manage fractious and uncooperative children. The condition itself requires lifelong control, yet the disease spectrum is wide with variable response to medical and surgical modalities. Most will require surgery, often in early childhood. Also, common associations with other ocular and systemic anomalies may limit prognosis as well as complicate glaucoma treatment. In addition, surgical complications and failures are much more frequent compared to adults. So why are surgical complications more common in children? In ophthalmic eyes, the thin sclera and distorted anatomy make surgery much more demanding. Healing capacity and fibrosis are also greater, making antimetabolites use necessary. Elastic cornea and sclera in the young means that wound and flap retraction can occur, and inadequate closure will result in wound leaks, hypotony, and shallow anterior chambers. In growing eyes, we need to deal with the possible device migration, progressive myopia, as well as amblyopia. Children are also dependent on caretakers and their care, and hence their compliance and motivation are essential. Follow-up exams and even minor surgical modifications and re-interventions, such as suture lysis, will be more challenging with need for sedation or anesthesia. Inability of children to report symptoms of complications, such as infection, may result in late recognition and poor prognosis for visual recovery. The visual prognosis of children with glaucoma used to be dismal uniformly before the advent of goniotomy in the 1940s and trabeculotomy in the 1960s, which dramatically improved the outcomes as the turning point in the management of this blinding childhood condition. The surgical repertoire for childhood glaucoma has remained largely unchanged with time. Most techniques have originated in adult and transferred and adapted for children. And advances have mostly been in the form of modification and combination of existing techniques and revisiting old ones. In the interest of time, I shall speak on common types of incisional surgery in children, namely angle surgery, trabeculectomy, and drainage devices. Angle surgery is the preferred choice for congenital glaucoma with favorable prognostic factors. Besides very high success rate, it also carries lower risk of sight-threatening complications compared to filtration surgeries, including hypotony and lifelong risk of bleb or device-related infections. If performed ab externo, it also preserves the conjunctiva for future surgeries important in the long lifespan of a child. In goniotomy, the trabecular meshwork is incised under direct gonioscopic view through the cornea. There are three keys to a successful outcome, and these are adequate access, clear visibility of the angle, and anterior chamber maintenance. Access can be challenging in ophthalmic eyes, and especially in eyes with very small or narrow palpebral apertures, such as in oriental eyes. To fit the gonioscopy lens and assess the peripheral cornea, we need to have gonioscopy lenses of different sizes. A lateral canthotomy is also useful to increase access. Visibility may be improved by increasing corneal clarity with preoperative IOP lowering medications, hypertonic saline, and removal of corneal epithelium, creating an epithelial window at the time of surgery. With regards to AC maintenance, a use of a tapered knife or 25 gauge needle without any prior tunnels or incision helps. Use of a needle mounted on viscoelastics enable reformation in case the AC is lost inadvertently during surgery. Filling the anterior chamber with viscoelastics prior to goniotomy or using an AC maintainer are alternative methods, but instilling fluids into these eyes can increase corneal haze and reduce visibility. It is also essential that the assistant does not place excessive pressure or distort the eye during surgery. Maintenance of the AC post-op by ensuring watertight closure of corneal wounds in the child is advisable to prevent AC shallowing and PAS formation, which can close off the goniotomy cleft and then affect success. This table sums up the complications which may be encountered in goniotomy, but they are very rare in centers of expertise. The commonest complication is that of transient hyphema, which occurs in almost all cases, but are usually self-limiting. It can be minimized by application of topical aproclonidine, which is an alpha agonist that can constrict the limbal vasculature. Usually I use a swab stick soaked with the aproclonidine on the scleral limbus overlying the area to be incised. In trabeculotomy is an incision of the inner wall of the Schramm's canal into the anterior chamber from within its lumen. The Schramm's canal can be accessed and cannulated from outside the eye, we call it ab external, or from the anterior chamber, which is ab internal. In conventional trabeculotomy, the Schramm's canal is cannulated ab external and a segment of the angle, usually about 4 to 5 clock hours, is incised. Circumferential trabeculotomy can now be performed ab external or ab internal with a suture or an illuminated microcatheter. The latest technique is that of GAT, or gonioscopy-assisted transluminal trabeculotomy, an ab internal method cannulating the Schramm's canal from within the AC, aiming to treat 360 degrees of the angle. The main advantages of trabeculotomy are that it can be performed in the presence of opaque corneas and accessible to most glaucoma surgeons familiar with trabeculectomy surgery, as there's no need for gonioscopic view, patient or microscope positioning. The complications and their management are similar to those of goniotomy. However, as the incision is not visualized in the ab external method, forced passage of the cannulating device or suture may also result in injury to the cornea, iris, ciliary body, and even retina. There's a greater risk of significant hyphema and hypotony with circumferential treatment. I have personally experienced a case of 8-ball hyphema in an uneventful circumferential suture trabeculotomy, which I've never seen with other angle surgery. Hence, we should be cautious in choosing circumferential treatment in children with clotting deficiencies or those with vascular anomalies such as Sturge-Weber syndrome. So what about trabeculectomy surgery? The need for lifelong control and a higher propensity for scarring meant that antimetabolites are frequently used, and that comes at a price. Even early post-op complications such as hypotony, flat anterior chamber, and choroidal effusions are more frequent due to thin elastic sclera in ophthalmic eyes, and also crying, straining, eye rubbing, and squeezing in children. Hence the need for meticulous technique, post-op care, and close follow-up, as well as parental compliance. Risks of bleb-related infections are also higher in children due to their inability to communicate symptoms, difficulty for the surgeon to examine for bleb leaks, and higher incidence of bacterial conjunctivitis in young children. Beware of infection post-trabeculectomy due to an at-risk bleb such as these: avascular, thin wall, cystic, and possibly leaking blebs. Bleb-related endophthalmitis rates in children can be as high as 9 to 17%, and they usually have very poor visual prognosis, commonly presents late, and almost always preceded by bleb leaks. To avoid bleb encapsulation and thin cystic dysaesthetic blebs at risk for leaks and infection, we need to achieve diffuse posterior filtration. To do this, we need to prevent posterior ring of steel fibrosis, which can result from limbal-based conjunctival flaps and inadequate tenon dissection. To optimize trabeculectomy outcomes, we need to perform fornix-based rather than limbal-based conch flaps with adequate posterior conch and tenon dissection. Rectangular or trapezoid flaps with a longer side posteriorly with adequate size and thickness to avoid flap shrinkage and retractions are essential. The side cuts of the scleral flap should start 1 to 2 millimeters posterior to the limbus to prevent anterior filtration. A smaller sclerostomy should be made anterior to the scleral spur to prevent overfiltration, bleeding, and vitreous incarceration. We should aim to treat a larger area with mitomycin C application. rather than focal treatment for diffuse bleb and avoiding posterior fibrosis. We should also avoid excessive MMC concentrations as well as application time and ensuring adequate saline irrigation post-application. So personally, I normally use 0.4 milligrams per ml of mitomycin C applied with sponge for a duration of between 2 to 3 minutes. Adequate tension in the scleral flap sutures, allowing for more flow from the posterior edge rather than the sides of the flap, is needed to prevent anterior filtration and cystic dysaesthetic bleb. Viscoelastic is hemostatic, anti-inflammatory, as well as being a spacer. So leaving in the viscoelastic in the anterior chamber post-operative can help to prevent AC shallowing in the early post-op period. And careful watertight closure of the conjunctiva is essential to avoid leakage, hypotony, and eventually trabeculectomy failure. So all blebs should be indefinitely observed when performed in the young. Always consider prophylactic revision of blebs at risk of blebitis and endophthalmitis, such as this kind of blebs, before infection happens. Also, early needling and 5FU for failing filters, and also for very focal and encapsulated blebs should be considered, because it can prevent the development of very cystic thin wall blebs. How about drainage devices in children? Not a single type of glaucoma implants has defined itself as being clearly more efficacious than others. The most commonly used drainage devices worldwide in children are the RMAT and Barbell implants. In a WGA consensus survey in 2013, 63% and 41% of experts surveyed used the RMAT and Barbell implant respectively. There's a continuous decline in success rate over time, with plate encapsulation being the major cause of failure. Non-valve implants such as the Barbell implants require a two-stage procedure or means of temporarily occluding the lumen in the early post-op period, which means that suture lysis may be needed and there will be interim high IOP. And if the occlusion is inadequate, there may be intractable flat anterior chamber or hypotony. Valve implants lessens the occurrence of post-op hypotony and flat AC, but are more prone to extrusion due to the shape and position relative to the muscles. There's also a greater likelihood of hypertensive phase in valve implants. Hence, the choice in the eyes, however, is the choice in the eyes with hyposecretion risk, such as in chronic uveitis. Valve implants may also be preferred in the very young and in ophthalmic eyes and those with follow-up challenges. There's less risk of hypotony and need for intervention under anesthesia to fix under occlusion in the early post-op periods due to the presence of the valve. What are some specific problems of drainage devices in children? The thin, elastic, impliable sclera with no rigidity means that they are more prone to migration, erosions, and corneal tube touch, and they are also more prone to hypotony and flat ACs post-op, even with the valve implants. There's higher risk of choroidal effusions and hemorrhage, and because the eyes are growing and may enlarge over time, tube migration is more of a problem than in adults. Due to the limited orbital space, strabismus and extrusion are also common. Because of difficulty with compliance with post-op care and post-op follow-up exam and management like with other surgery, and there's also a frequent need for sedation and anesthesia, managing these children may be a challenge. Some surgical tips in children to achieve better exposure and access will include lateral canthotomy, and doing adequate hemostasis, peritomy, and a very generous conjunctival relieving incisions means that you have a better view in anchoring the plate far enough posteriorly. The tube should be sited preferably in the superior temporal space whenever that is possible. And also we need to avoid areas of thin sclera and PAS when we make an entry into the anterior chamber. The plate should be anchored at least 8 millimeters from the limbus for the RMAT implant to prevent slippage anteriorly. To prevent hypotony, long snug limbar tunnel incisions with 25 gauge needle to prevent peritube leak is important. So I don't use anything more than 25 gauge normally, which means that the insertion into the AC is snug. And a two-stage implantation for non-valve implant with adequate occlusion, as we mentioned earlier, is essential to prevent hypotony. And viscoelastic left in the anterior chamber at the end of surgery will prevent immediate post-op hypotony. Anterior tube migration can be prevented by securing the tube and plate really well with nylon sutures and placing the barbell behind the recti. Posterior tube migration can be avoided by using a shorter intraocular portion of the tube and securing the tube properly on the sclera. To prevent corneal decompensation, the tube should be placed as far away posteriorly as possible in the anterior chamber. Also avoid too long a tube that's aimed at the central cornea. So normally you should place the tube obliquely rather than straight into the central cornea. Consider sulcus and pars plana tube in those with intractable anterior segment complications. In aphakics, consider interior vitrectomy to prevent tube obstruction. And extensive posterior vitrectomy is essential for pars plana placement to avoid vitreous from obstructing the tube. Inflammation should be treated aggressively. And the tube should be left slightly longer in those at risk of PAS, for example, in uveitis and in those with epithelial ingrowth. The tip should be visible wherever the tube is placed, whether in the sulcus or pars plana, so that we can always observe the tip for occlusion, either by the vitreous, iris, blood, or other fibrin. Okay, to prevent tube erosions along intrascleral tunnel with entry into ACS posterior to the limbus as possible is essential, and we should avoid cornea entry because that's more likely to erode. Oblique rather than perpendicular entry into the eye can avoid a tube knuckle that predisposed to extrusion. Patch graft should be used to cover the extraocular portion of the tube, and scleral, cornea, or tube-to patch can be used. And now I personally prefer fascia lata graft in children. Good conjunctival closure over the limbus without tension is essential to prevent erosion, and the tube entry point should be covered by the eyelid. Delayed endophthalmitis is almost always preceded by tube exposure, so hence the importance of education and regular follow-up observation. Generally, exposure develops close to the limbus, usually within 1 millimeter of the limbus, and prompt revision of the exposed tube is needed. Placement of patch graft and mobilization and repair of the overlying conjunctiva is usually done, and recurrent erosion refractory to patching may require pars plana placement of the tube. In conclusion, surgery is crucial in the management of pediatric glaucoma, and childhood glaucoma surgery is more challenging in children with high failure and complication rates compared to adults, and should be performed by trained surgeons in centers with safe pediatric anesthesia. The first surgery is often the one with the best chance for success, and therefore appropriate choice of surgery and careful consideration of risks and benefits of each intervention should be carefully considered. Modifications in surgical technique are often required in children to prevent complications that can limit outcomes. Other than IOP control, ametropia and amblyopia therapy are essential to maximize visual potential. Thank you for your attention. I apologize for not being able to attend the meeting live as I have a prior engagement, but I hope that you have a very enjoyable and fruitful meeting. So take care and stay safe. Goodbye.
Good afternoon.